like furunculosis or folliculitis. They are also prone to oral candidiasis as well as esophageal candidiasis. And coming to genitourinary tract, they are more prone to UTI as well as pyelonephritis and renal abscess and systemic sepsis.
Please. So basically, as we said, any infections are common in the diabetes, but specific infection which we're looking for, emphysematous pyelonephritis, emphysematous cholecystitis, malignant otitis externa, and as we said, arrival cerebral mucormycosis is very common. We have a good experience from the COVID era. So any pharmacology resident there? So we have a 42-year-old diabetic patient who's admitted with melanitis in the ward, and this is his prescription. So please analyze this prescription and suggest any amendment required.
Sir, it is a long-acting, Glutic is a long-acting insulin, sir. And then we have metformin, which is barigonide, sir, sitagliptin, and dapagliflozin, sir, which is SGLT2 inhibitor,
So any question required? This is fine. I give you information that you are very welcome. So please say. So basically, just focus on this drug with dapagliflozin, which is SGLT2 inhibitor, which causes the glucosuria, which can cause genital and urinary infection. So we gave you information that patient has a melanitis. Please take it. It's a very common clinical scenarios which we face, and in this patient, we should go ahead and stop the SGLT2 inhibitors. And why did our sensory complaints worsen, Akash?
Sir, historically, when we saw her history, the patient had features of likely diabetic neuropathy, sir. Now that we are giving her insulin and the sugars are controlled, this can be because of the insulin-related neuritis, sir. Once the sugar gets...
So whenever the patient is having a prolonged hyperglycemia and you suddenly control the glucose level, patient can have worsening of the neuropathy. And this is seen in both type 1 and type 2 diabetes. This is called as TIND, treatment induced neuropathy or insulin neuritis, and probably that happened in this patient. There are various mechanisms which have been postulated like endothelial ischemia, but this is an important entity which you should remember because this generally does not require much treatment and recovers on its own. And if we are psychiatric, a patient has some psychiatric manifestation with respect to her mood, etc. So what are the diabetes specific psychiatric thing which I've already told, the diabetes distress, etc. What is diabetes distress?
Sir, diabetes distress is an emotional reaction or an affective response related to the diabetes, which may be anger, guilt, worry, related to the diabetes and its burden, which is more common in the diabetes patients. So that is affected. Sir, it is required treatment. The psychoeducation supportive therapy will be the mainstay of treatment in the diabetes.
So it is a problem with respect to accepting that you have a diabetes and with the burden how to go about the managing diabetes, which is seen very commonly in the patient of diabetes, which generally does not require any treatment and recovers in its own with a simple psychotherapy. But it can progress to major depressive disorders. But in an appropriate setting, it is very important to differentiate between two because the other can be a counter very land up with a disastrous outcome. So this is how it happens. So because the patient feels a burnout burden and land up in distress, and they can go into the diabetes depression. And these are the features which residents are very aptly brought out. So you can have just burned out feeling, unmotivated, denial, loneliness, etc. Simple milder behavioral abnormality. On the contrary, in the major depressive disorder, the patient can move into appetite changes, psychomotor agitation, and retardation. And these two situations are more important. I would say this distress is the important stage which should be picked up because appropriate management leads to very good outcome, not only with respect to psychological health, but also with your physical health and diabetes target management. So what is metabolic memory, Ram?
Sir, early glycemic control, which is by insulin, there is a legacy effect which causes less long-term complication, microvascular.
So as we discussed earlier, when you treat the patient initially with insulin, you are doing the exercise to regenerate the beta cell because glucotoxicity is lowered. And once you have a good glycemic control during the initial days of your diabetes, the studies UKPDS trial, which I'm quoting, that this leads to the very good profile with respect to complication, even if you lose your diabetes control subsequently. And this is called as a legacy effect of metabolic memory. And why it is happening? Because of the various epigenetic changes and changes in mitochondrial function. And this is not just for interest, a fancy name, but this is a very well documented in very large trials like UKPDS. So this is an important thing which we should apply in the practice.
Coming to the hospital course, my patient responded well to the therapy. Her sugar levels were optimized. She had symptomatic improvement with weight gain of 5 kgs in 3 weeks. Summarizing the history, we have a 41-year-old lady who presented with complaints of weight loss for 1 year duration with paresthesia of both lower limbs. She was managed as a case of uncontrolled hyperglycemia, diabetic cachexia with basal bolus regime and nutritional buildup. Her insulin was optimized. However, she developed neurological worsening, which was managed symptomatically. She had a symptomatic improvement with weight gain of 5 kgs in 3 weeks during the hospital stay. She was discharged on basal bolus regime.
So how do we approach the diabetes management with respect to target in geriatric population?
Sir, with respect to the geriatric population, we divide them into 3 categories. Sir. Basically, we categorize into group 1, 2, 3. Group 1 is the fit older adults, sir, without any comorbidities or non-frail patients. Sir, we have a good control in them. Then the next comes the frail elderly, sir, in which the HbA1c target is 7 to 8, sir.
Please. Good. So it is just a matter of how disabled the patient is. If they don't have any social support, if they have a disability, they are frail, please maintain a target of 8 to 9%. If they are fit, you can target 7%. And this is a very common problem. And the geriatric resident would agree with this. A lot of people have a problem with the hypoglycemia, and this have landed up with the fatality also. So any nursing officer students here? So you've been given instructed to give a Lispro insulin, and these are 2 insulin which are available in your ward. So which insulin out of these, on the left or right, which one would you give to your patient? So we can see both of Lispro is written, both of them.
Sir, the first file, the plain Lispro, sir, Humalog.
Which one? This one.
Yes, sir.
Good, please, sir. So this question has been taken from the error which we have committed in the ward. What happens is, this is the Lispro, it's a plain Lispro, but this is also Lispro. At times we give this as a rapid acting levodopa-prandial insulin, but actually it is not a true Lispro, it is a mixed insulin. Read it. It is a Lispro plus protaminated Lispro, means it is equivalent to the mixed insulin. So it cannot be given in lieu of this. So any other nursing student, nursing officer student, please? So you've been given, asked, so we have a vial, this one, with this strength, U100, please focus on this, and you have these 2 syringes. So which syringe you will use to inject this insulin?
Sir, for giving insulin Lispro, we'll use the syringe which contain 1 ml 100 international units.
So 1 in 100, orange one.
Orange one, sir.
Very good. So this is again is taken from the mistakes which have happened. So U100, please use the 100 unit syringe. If you have a U40 strength insulin, please use the 40. Because if you load 100 units per ml in a 40 units syringe, what will happen? You will administer 2.5 times higher insulin. That will lead to the fatal outcomes. How do you store insulin? Any nursing officer? Any other nursing officer? How do you store insulin? So basically, with respect to insulin administration, these are fitter guidelines which were given by the AIMS and all the renowned institutes, and these are the validated thing which every one of us should be reading, and this gives the detailed information. So insulin can be stored in the room temperature. If it is around 25, in this literature refer 30, but I would say around 25 is good. But if you would travel, please carry if the temperature is higher, people can carry it in the flask containing a cold water and insulin wrapped in the plastic bag. An ideal site of insulin injection is the abdominal wall because it has a neutral area and it is a larger space which is true subcutaneously, and the insulin, this area does not, metabolism of this area is not affected by your day-to-day activity. Thigh has a motion throughout the day and that is affected. So how to take the insulin? Take a pinch, and if you have a 4 to 5 millimeter, 6 millimeter needle, you can simply 90 degree inject it here, and you keep on rotating the side so that there is no lipodystrophy which happens. It has been seen that if you give it in the thigh, so if you use a 6 millimeter, which is commonly used, you can 10% of the time the injection can go into your muscle, but in abdomen it will happen only in 2.8% of the time. That is why your abdominal area is a ideal site to give the insulin injection. So with this, I'll come to the aim of today's presentation. So aim was to highlight the very basics of diagnosis and management of diabetes, to highlight the common mistakes which happen during the diabetes management, and to recognize that diabetes is increasingly affecting and percolating to all the social and economic strata, as it happened in our patient. And this case was also selected on the basis of feedback which was received from the faculty